Hello and welcome to another episode of Pakistonomy. My name is Uzair, and today we're going to be having quite an interesting conversation about something that, at least I, growing up in a family with two doctors, anecdotally was have been aware of. Many of you who are listening in who have lived in Pakistan, live in Pakistan, or have any experience with doctors or the medical industry in Pakistan, kind of have heard these stories, right? That a lot of times doctors prescribe medications to patients because there are some incentives involved from the pharmaceutical companies, from other types of actors who get you to get access to certain medications because there's some financial or non-financial incentives involved. But it's something that is not unique to Pakistan. It happens all over the world. But in the Pakistani context, while a lot of us have this anecdotal evidence, we just never have had robust enough research to point to this phenomenon and understand what's causing it and what can be done about it. So today, I'm joined by Mishal S. Khan, who's professor at the London School of Hygiene and Tropical Medicine in the UK, and also visiting faculty at the Aga Khan University in Pakistan. And Mishal has done some great work on this topic and some amazing findings in terms of what exactly is going on with incentive link schemes for doctors, etc. So, Mishal, thank you for your time and for your research, and welcome to Pakistonomy.
Yeah, it's great to be here and to be having this discussion with you.
And this is one of my favorite things about the podcast, right? When some new academic paper comes out that is interesting, that I kind of know it links to the economy, it's always great to have a conversation with the researcher. So I want to start with the basics, right? Help us understand what are the key findings from your research and what is it telling us about the state of the pharmaceutical industry and the medical industry in the country?
Yeah, so let me tell you how we kind of got started on this, right? So one of the issues that we were initially tackling as a team with the Aga Khan, and it's a global issue, and that was of drug resistance and particularly resistance to antibiotics. And to cut a long story short, when we got to the end of some of our other work, one of the key challenges that policymakers were highlighting is that with medical professionals, if you can keep sort of doing trainings on the right medicines to use when, but actually it's not a knowledge gap. There are these incentives at play that are really often pushing over prescription of medications, not just antibiotics, but this was found in the context of antibiotics where there's a really severe public health risk of drug resistance. So that's where this started from, and this was like an area that's been poorly addressed, the kind of the incentive side of behaviors around prescribing. And what we did was two things really. One is because the deals that are made between pharmaceutical industry reps and doctors, which, as you mentioned, are kind of it's like an open secret. You talk to anyone in the field and they know about it, but because it's not something that is also kind of necessarily owned up to in public. So these are hidden deals. So one of the key issues is actually knowing, how common it is and what happens. So we developed a new method to be able to actually assess that, and I can talk about that. So that was one key bit of our work. And then the second was to try and see if we could reduce how often and how common the practice of these deals doctors making to prescribe certain medicines are. So we looked at two things, and I can tell you a bit more about that.
And so that again, right? It's like one of those things where it's an open secret, but you can't really uh, back it up with data. Plus, the field of healthcare and doctors and patients who have relationships with doctors, often it's a relationship of trust. You're trusting this expert to make in a white coat, often to make the right choice for your health or your loved one's health, right? And you don't want to accuse them holistically of something that you kind of feel about but don't really fully grasp with, right? So what did you find, first of all? Like what were the outcomes? And I want to go into the methodology a bit later as well. But
Yeah.
since people, I think, first question will be "Pata kya laga?" So let us
Yeah, sure, of
share with
course.
us, like, what is it? What exactly is going on here?
Yeah, so what we found was that doctors essentially and we looked at Pakistan, doctors in Karachi, private doctors providing primary care. So I can go back to why the private part is important. But what we found is that 40% of them in our sample, which was about 400 plus, made a deal with pharmaceutical sales industry representatives within two interactions with them, without knowing anything about the quality of the medication or the company. The deals were basically around, okay, we will prescribe the medicines that you are promoting in return for various incentives, the most common one being like a direct kickback, but also clinic renovations, meals, etc. So what this meant was that they were willing to kind of commit, irrespective of knowing which patients are going to say like walk through their door the next month, that they will commit to having, a certain number of the medicines prescribed, 40%.
Wow. So in essence, the doctors kind of made up their mind that they have to hit certain targets.
Yeah.
And regardless of, type of patient, their symptoms, etc., they know in the back of their mind that they gotta hit those targets and therefore will be more likely to prescribe that medication because of these incentives involved. Now, I want to ask you a follow-up, right? In this, like obviously there are engagements that are done with doctors on ethics, on things that they should and should not do. In the case of Pakistan, the Drug Regulatory Authority has banned the use of gifts, etc. So one would imagine that if there is this training component involved and there is that stick as well from the regulator or the authorities that be in the country, that should act as a deterrent. And I want to hear your thoughts on like, does that help? Does interventions in terms of telling doctors that, look, this is actually terrible, it's bad, like you entered this industry, this like amazing, amazing industry where you can positively impact people's lives, save their lives, prevent their loved ones from going down a path that, of ill health and maybe even death, God forbid. Don't do this, right? Does that work in this environment, or what did you find there?
Yeah, so for the second bit of the work, which we did essentially a randomized trial, so we divided people, the doctors, the 400 doctors, randomly into receiving an intervention where we got them together in a room. We had a video about the impact on patients, the financial impacts, also the impact on like the doctor's conscience. We got regulators in the room. We did group exercises. So I'm giving you this detail just to say that, within the context of like an educational emotive seminar, we did everything that we could from the perspective of researchers to push the different, buttons in someone's head to really get them to take this issue that's been normalized seriously. And despite that, so there was a reduction. So from like a 42% of doctors accepting it without having this intervention, 32% accepted or agreed to make these deals when they were exposed to all that messaging. So there was a small reduction, but wasn't really, I would say, substantial enough to have the kind of public health impact, because still quite a large chunk of doctors were making these deals. So kind of going back to what you were saying, our conclusions are that while this kind of emotive and conscience raising element is important, having the regulatory aspects and having that implemented is really important too. And secondly, so you'd mentioned the Drug Regulatory Authority of Pakistan. So just to clarify that their kind of mandate is over pharmaceutical companies, and that's why we were really focusing on doctors. And what's striking is that even something like just a regular continuing medical education, once you become a doctor, it's been mandatory in the past, but there hasn't been like a consistent period where there's, okay, you have to have these credits, both on kind of updating your knowledge or your ethical practice. So even to get doctors in a room, it's completely voluntary. They don't have to come, they don't have to stay. So to get them to engage on really important topics like this is quite challenging.
Yeah, and I think again on the pharmaceutical company side, right? That was going to be my follow-on question. Like this is a global issue. It happens in the United States where I live as well, and it's been documented. There have been studies done on this. And really regulator, I think, is much more effective in terms of deploying the stake on the organized pharmaceutical sector, right? That you cannot do certain things. I mean, for those of you who are good, TV show watchers, there was a really good show made on the what do you call it, the opioid epidemic in the United States. Dope Sick is the name of the show. Covers sort of the Sackler family and the entire sort of opioid epidemic that Sackler family enabled, and they were taken to court. And to this day, like certain monetary impact fines have been issued, but a lot of people are still unhappy that not enough was done, but at least something at a large enough scale was done to make the headlines in the Wall Street Journal, the Financial Times, etc. And that's where the stick gets deployed, right? That if you are a big pharmaceutical company engaging in these practices, the regulator sort of does regular surveys, keeps an eye on you, and if you start doing things that lead to issues like addiction or antibiotic resistance, we're going to come down hard on you, right? And again, even in the developed world, there's a lot of public pressure to do more. I was just curious to hear your thoughts on like how where are the challenges on the regulatory side in Pakistan on the pharmaceutical sector? Because in my mind, one area where I think I kind of think about this issue becoming harder to tackle is that a lot of the multinational companies in that were in the pharma sector in Pakistan are exiting, which means that
Yeah.
you have smaller and smaller operators in this sector, which are, more local. They have their own political, connections, etc. And you cannot use the MNC lens to coerce them to act more ethically because MNCs obviously are much more attuned to global reputation risk, etc., and also are exposed to global lawsuits and all of that stuff. Was curious to hear your thoughts on like what the regulatory authority in Pakistan is doing or what can be done more about it to use the stick end of this on the pharma side, because that's where the incentives come from.
Yeah, and so as one of the things you already touched upon is just the number of companies and the proliferation, right? And that I think if you kind of marry that with regulators in contexts like Pakistan who are under-resourced and there's all those conflicts of interest issues. So if you've got a regulator that's perhaps relatively struggling, and then there's a very large voice of companies that already makes it difficult. And a natural step is to limit how many companies and how many drugs for a particular compound. So one of the things that's really striking in Pakistan is if you take a specific antibiotic and you see like how many different forms of, how many companies can make exactly the same thing and be selling it. It's huge. And some countries have said, okay, like, once we've got 10 or 20 or whatever's a reasonable number of this compound, we don't need like the 55th one, because what it does is it creates these turf wars, which is what we saw in our research, that pharmaceutical companies are then competing for this a limited number of patient pools, and then the companies are increasing. And then what they end up competing on is those incentives. So a linked issue with that is also that the quality is not really regulated and monitored as quickly. So if you're thinking about it from the point of view of a pharmaceutical company that's just coming in it for making money, it's like, well, I need to give as big a chunk of the income that I'm generating to the doctor, because that's effectively what I'm going to be differentiated on, and then I'm going to squeeze all the other costs and the quality. So it's really like a double whammy in terms of the impact on like the medical profession and the ethics and the quality that the patients receive.
That's fascinating. And then, now I want to jump into some of the methodology, right? How you went about doing this research, because again, it's not easy. Doctors aren't going to tell you over an open questionnaire that they engage in these practices, or, here's how we get incentives from pharma companies. The pharma companies obviously will not want to tell researchers like you and your team what they're up to as well. So how'd you go about finding out the fact that about 40% of doctors engage in these practices that, to me at least, are grossly unethical, and some audience members may even say are criminal in nature and should be tackled? But how'd they tell you this? Like, is my question.
Yeah, and so this is the first time this new methodology has been developed and used. And what we did was we trained our project data collectors to pose as representatives of pharmaceutical companies. We hired people that actually often had experience of working as sales reps. So they would go into clinics and say, look, I'm coming actually from a new company. It's a new company and it's a franchise. So this concept of, companies that have a headquarters somewhere else, but just using like this marketing sales force, right? So they would say that we're a company based out of Punjab, but we're looking to expand our market share in Karachi. So this is a list of the medications that we have available, and what can you do to support our sales, and what would you like us to do to support you in return. So it was very much like a real life scenario, and the doctors were not aware that they were being assessed in this way. So they had their kind of natural reaction. Interestingly, so being a research project, we had all the ethical approvals in place, but also we were kind of looking out for whether any of the sales reps got detected as being like imposters, and none of them did. I think that's partly because doctors are seeing so many sales reps, and people are just in and out of their rooms amongst the patients, that they didn't, no doctor actually took the time to Google the name of the fictitious company, because if they had, they would have found that it doesn't exist. So
You
that's
didn't you
where
didn't set up a fake website and a
no,
fake
we didn't,
LinkedIn, all of that.
no,
Okay.
and we didn't give any samples, which is very common too, because there were certain ethical things that we couldn't do either. So we came with a bunch of limitations, but despite that, 40% agreed. So that's why I do want to emphasize that the 40% is really like the it's that bare minimum. Like if it was companies that they recognized, and they did say this actually. So the 60% that said no, thank you, were saying it's because we're already working with MNCs or other companies that we recognize. So the vast majority were engaging in this behavior, and 40% were happy to say, hi, we've just met. I don't know you or your company, but if you're going to give me something, I'm willing to give your medications
Yeah.
to patients.
Yeah, you didn't have to work super hard, right? Like throw a party, take them on a trip, etc., which a more established company probably would be doing. And again, that threshold, as you said, is the easiest thing you could hit with the limitations ethically that you had as researchers, 40%. So if you were to do, my guess is if the Drug Regulatory Authority of Pakistan did a bunch of mystery shopping as part of its quarterly or biannual sort of surveys across the country, I think they would hit significantly more than 40%. But again, we can only speculate. But at least now we know what's going on in this space. One thing that you also highlight in the research, right, is that there's obviously the doctor's incentives and the pharma incentives. We've touched on that. But part of this pressure also comes from patients who want faster recovery in terms of specific medications that they want. And that stood out to me as a very interesting point because, again, I've seen this in my own family where people would be like, hey, give me antibiotics. I'm sick, give me antibiotics. Like, you have to explain, my brother and my sister have had to explain to a number of friends and family that you shouldn't go down that path because, especially when you're young, because you will develop that resistance over time, which means when you are actually really sick, it's not going to work as effectively because you've been just popping antibiotics for a number of years. Um, so I was curious about like if in that environment where there's pressure coming from the patient, like how do doctors typically deal with that part of the puzzle, right? Because you kind of not only have an incentive, but you're also being pushed almost by your, if I don't want to use this term, but like it's like you're already addicted and hooked onto a certain type of prescription and you want that. Like how do doctors deal with that?
Yeah, so you're right. So there's really both, especially in like in a private sector setup, right? And this is what we're talking about. Your client is the patient. You want to make them happy. You also have this hidden incentive, and also you don't have actually that much time. I think that's one of the things that really stands out again in Pakistan is, it's often a 2 to 3 minute consultation for patients, and
I've
they,
been through that. I've been through that.
yeah,
Like, yep.
and it's just not, it's not conducive to really diagnosing a patient and also counseling them, because in all contexts this happens around the world. Even, you say here in the UK, doctors say that if you need to kind of convince someone to wait it out or do something like steam or something that's non-medical, it requires a bit more of that counseling time, but ultimately it's better for the patient. So I think all of these factors do work against having that more what we'd call patient-centered care, which is about what would actually work for them, and not what's either the quickest or the most sort of financially beneficial thing to do.
Yeah, that's interesting. One sort of in the last phase of this conversation, I want to talk to you about like what can be done from a regulatory and policy side to deal with this, right? Of course, we have this, there's more research. Curious to hear your thoughts on like what more research is needed in this space in Pakistan to dig a bit deeper as well, because I think this is, correct me if I'm wrong, the first study of its kind in this space in Pakistan that at least gives us some data. So, what do you think is still needed in the field of research on this? And then, secondly, your thoughts on if there is a policymaker in Islamabad listening to our conversations, and I'll link your study and sort of like, profile, etc. So maybe you'll get some more pings after this conversation from people. But what should we be doing about this is the question.
Yeah, so I think that, one of the first steps is for, all the different stakeholders to understand why this is an issue. So, because so far it kind of is working for everyone, right? It works for the pharmaceutical industry. They sell, it works for doctors who are engaged in getting kickbacks. Patients are happy, and policymakers are seeing growth of the pharmaceutical industry, and there has been a reluctance to curtail that growth. So I can see that. But for everyone involved, whether it's the pharmaceutical industry having to spend much more on these kind of marketing practices than drug quality, the impacts on patients' health and their finances, and for doctors, there is increasingly a loss of this trust. There are public conversations about this, and losing that kind of that faith that patients have is going to be like, there's a lot of long-term detrimental impacts, even though in the short term it seems like a good thing to do. So to really highlight, to be aware of that, and to start thinking about some of the more structural solutions. And by that I mean, do we need to kind of think about how many medicines of the same type as I mentioned are out there? And I don't think we can really even get away from the conversation about thinking about more public financing for health. So when we've talked about this being an issue in a lot of countries, and I think the US is a good example, but that's also another country where there's a lot of people just paying for care directly or through insurance. But if you compare it to countries such as the UK, where there's no, you're not paying for your consultation most of the time, and there's no real incentives for a doctor, therefore, to overprescribe. In fact, there's limitations. I think as a patient, you get a much better quality experience, because that whole element of is the doctor getting something from this is just taken out of the picture. And so would we be able to move to a model where there is more of a publicly funded system of healthcare, which I know is far away, but ultimately we shouldn't, I think, assume that this happens everywhere. It doesn't. It happens more in countries where it's private healthcare and patients are paying out of pocket.
Yeah, and I think the insurance part is very interesting and important, right, as well, because in cases where, insurance incentivizes certain types, we've seen this, I've come across reports on this, that it incentivizes or covers certain types of surgeries, right? So putting a stent into your heart is like covered, and it's a profitable surgery for the surgeon, and the insurance will pay for it. It's incentivized for the doctor to just tell your patient to go under the knife for a stent, as opposed to long-term lifestyle interventions that, can solve that same problem for that patient, and actually in the longer term are better because your lifestyle is, and diet and etc., exercising regimen is much better. But that doesn't have a payout in the same way inserting a stent does, because of the insurance dynamics, right? So your point on that is well taken and made me think of that example as well. Last question related to that then is like, of course, that will take time. The structural interventions, et cetera, are important, necessary. We need to have a conversation about it, but it
Mm.
takes time. But there are people in Pakistan, that go to, who may be listening to our conversation, that go to, or their loved ones go to doctors, right? And it's private healthcare. That's what you have. How should individuals or family members of individuals think about this issue, and deal with it in the context of their own interactions? Like, do you have any advice or thoughts on, as an individual, if I'm going to a doctor and it's in my mind that they may prescribe me something that I don't need because of these incentives, like, are there things I can do to, balance against that incentive structure? What should we be doing?
We could, I think the main thing one could do is really just make sure you understand the medicines that are being prescribed and why, and ask about that. I think it's quite risky in a way to put too much responsibility on patients and individuals, even though, I see where that's coming from, but I think it sometimes takes away responsibility from the state. And this issue, I think, is one where the regulatory systems need to be strengthened. So as individuals, I think we should be asking questions of what are the regulators doing? Because I think this, you can start then checking on doctors, and you're going to checking on your food ingredients, and like where as an individual, how much if you do that, your all your sort of conscience and your energy is going to be used on checking up on people and products that you should be able to trust, or is
If I may interrupt, go down a path of Googling everything and then ending up on
yeah,
blogs that say vaccines are terrible, therefore don't give your kids vaccines. And I'm like, that's
yeah.
horrible. That's also a path as an individual you don't want to go down.
Exactly. And sometimes, and it's not great for doctors either, because sometimes there will be a genuine need. So, because this, it's got the economics background, this idea of information in asymmetry. And like, so there has to, doctors will know more, and you have to be able to trust them. In order to be able to trust them, there need to also be like these regulatory systems and be like, okay, these are also human beings. If they're being incentivized, they might stray. So there have to be these structures that allow patients to be able to go in and talk about their symptoms and their concerns, and not also be having to double check,
Yeah.
because that really throws everything off.
And I think, again, from, if you're a healthcare professional listening to this, and maybe this annoys you because you're like, nahi sab nahi karte, or you're like, okay, if you're, I know it, if my brother is going to listen to this and he will say, I told you 10 years ago this is how it works, right? And then the thing is, if you're, as a doctors association, and you obviously, they're also parts of communities. This is what you got to solve for internally yourselves as a community, because it erodes, to your point, right? Public trust. And we don't want to be, no society wants to be in a position where public trust in doctors who are in it for public service and saving lives are not viewed in the same way because of this 40% level of people who are willing to take incentives. So at some point, the responsibility is on you, that if you want this trust to be everlasting, and it's a very important relationship any human being can have with their healthcare professional, you got to do something about it internally as well, to reinforce that trust as well. So I think that I agree with you. Don't put the burden on the individuals, because in our world of the internet access that people have, that will is a pathway to disaster in terms of trust in healthcare professionals, and we don't want to go down that path. So once again, thank you for that research, and for, confirming a lot of the anecdotes we listen, and hear about in the Pakistani context. I know there's more research to be done, but at least this charts a new course forward for the discourse on this topic. Before I let you go, I always ask my guests, what are two or three books you would recommend to the audience?
So one that has really stuck with me, sorry, is it's called Why We Sleep by Matthew Walker. It's a very specific topic, but it you'd ask for things that have actually changed my lifestyle. So that has. And I guess on a personal note for me, it's a bit of a depressing time in the world. So I've just been reading poetry, and I guess a lot of people will be familiar with Faiz and Hum Dekhenge and the shorter things. I like to read, because when I'm thinking about these complex issues that can't be solved, and global politics, and all that's happening, you just sometimes need something to give a bit of longer term hope.
Yeah, on that, I agree with you. I've sort of, over time, prefer reading nonfiction. That's just been, I enjoy that more. But over the last few months have switched to more fiction. I just feel
Yeah.
like it's a way to escape into another reality, and not have my mind constantly focus on the here and now and what's going on in the world. So I agree. I'm not a poetry, like it's never like I tried, doesn't really stick with me. Maybe at a later point in my life might evolve enough to understand and appreciate poetry, but I've gone down the fiction route, related to your point. So, point well taken on that.
Yes, yes. And I know you were living in a place with a new leader coming in, which
Oh,
might
the
need some escapism there.
Yes, and especially in Washington, D.C. Like I had a friend of mine, a colleague of mine saying, "Oh man, like I can't believe I'm going to live through this experience." And I was like, "This is your first time. I've been here. I was there 8 years ago, and I will survive through this. I do not need this at this point in my life, but here we are." But again, thank you for this research. Kudos to you and your team for doing that. And I hope I'm sure the audience found this helpful and insightful. And I know there are a lot of doctors that listen to this, so either one of us may start getting a bunch of comments and questions. So thank you for all the work that you did here.
Yeah, thanks for having me, and yeah, thank you to my team as well.